All right, we talked about the bony landmarks at the proximal femur when we were talking about the hip, and now we're going to go down to the distal femur and the proximal tibia when we're talking about the knee. So the learning objectives for this are the same as they always are for osteology. I want you to be able to identify the bony landmarks of each joint and their anatomical position to one another. And then, of course, in the lab, you are going to palpate the different bony landmarks. And so we'll talk about which ones are palpable and which ones are not. So the knee appears to be a pretty simple joint. And in fact, when I was in school, they used to talk about the knee as a hinge joint and only talk about flexion and extension of the knee, but it's actually pretty complex. It's two joints, the tibiofemoral joint and the patellofemoral joint. So the joint between the tibia and the femur, and the joint between the back of the patella, the posterior side of the patella, and the patellar groove on the femur. The knee is supported and maintained by extensive muscles and ligaments. It lacks bony stability, so it needs all those muscles and ligaments to really stay stable. Our knees are exposed to severe stresses and strains, which is one of the reasons why we see knee problems so many times in physical therapy. So we're always treating knee osteoarthritis, knee injuries, knee strains, knee pain, knee replacements. So lots of different things. So hip and knee replacements are the most common elective surgeries in the United States at this point. And no matter what setting you work in physical therapy, you will see people with hip and knee replacements. And you will see people with other knee injuries and surgeries. It is one of the most frequently injured joints in the body because we use it for everything. So really important group of muscles, really important group of ligaments, but we are going to start out talking about the bony landmarks. So the distal femur, we have basically the knuckles of the femur, if you want to think of it like that, the medial and lateral condyles. They're projections of the distal femur that articulate with the medial and lateral condyles of the tibia. So if you recall from chapter 2, talking about condylar joints, which the knee is a condylar joint, we're talking about a fairly rounded convex surface articulating with a fairly shallow concave surface. So that is one of the things that provides the instability. But the other side of the coin on instability is mobility. So if you can think of stability and mobility as being on a spectrum, with stability being at one end and mobility being at the other. So in terms of joints, the ones that are the most stable, like the synarthrosis joints that transmit forces, those are the least mobile. And the ones that are the most mobile, like the diarthroses, and like think about the shoulder, how much it moves. It's the most mobile, it's probably the least stable. So on that spectrum from stability to mobility, the condylar joints have a lot of mobility and need a lot of ligaments and muscles for stability. The intercondylar groove, also known as the patellar groove on the femur, is the smooth, rounded area between the femoral condyles on the anterior side of the femur, and that articulates with the posterior surface of the patella. So the intercondylar groove, sometimes also called the patellar groove. On the posterior side, we have the posterior inferior aspect of the distal femur. We have the groove, the notch that separates the medial and lateral condyles. That notch forms the passageway, and it's where the ACL and the PCL live. So there's room in there for those ligaments to be inside the knee, stabilizing it. And we'll talk in one of the upcoming lectures about how that works. The medial and lateral epicondyles are bony projections that are on the medial and lateral femoral condyles, just superior to the articulating surfaces, and they serve as attachments for medial and lateral knee ligaments, medial and lateral collateral knee ligaments. The medial epicondyle is just inferior to the adductor tubercle. So you may recall the adductor tubercle from the hip osteology. The proximal tibia, the medial and lateral tibial condyles articulate with the medial and lateral condyles of the femur. The flattened superior surface of the condyle is called the tibial plateau. So here's a kinesiology geek story. I was in Silkeborg, Denmark, and they have a museum there where they have one of the best preserved bog people ever found in Europe. And so you can see a lot of the little bog person's bony landmarks, and I was taking a bunch of pictures of it, and I'm like, look at that, you can see his tibial plateau, you could really see his tibial tuberosity. And the lady who was standing next to me turned and looks at me and she said, well, now you have a lot of pictures of the deadest guy in Denmark. So, you know, but bones are interesting, and a lot of bones, human bones definitely have the same landmarks. And sometimes you'll even see animal bones that have very similar structure. So another time I was at the Johnson Space Center in Huntsville, Alabama, and for some reason they had mastodon bones there. I don't know why they had mastodon bones at the Space Center, and they wouldn't let us take pictures of those, or I surely would have. But in their lower extremity bones, you could see the same structures. You could see the tibial plateau and you could see the tibial tuberosity. So form follows function. We have muscles that attach to certain places and we have certain functional things. Of course, the mastodon bones were much beefier than human bones because, you know, mastodons were bigger and they need stronger bones. But a lot of the same bony landmarks can be seen on lots of different skeletons. So if you're a kinesiology geek like myself, go to museums and take pictures of bones. It's fun. So the tibial plateau has two little points in the middle. They're called the intercondylar eminence. It's a double pointed projection of bone that separates the medial and lateral tibial condyles. And they are attachments for the anterior and posterior cruciate ligaments and for the medial and lateral meniscus. So the meniscus is going to sit on the tibial plateau and it helps to deepen the attachment site a little bit more so the condyles can fit a little bit better. The tibial tuberosity is the protrusion of bone that's located on the anterior aspect of the proximal tibia. It's the distal attachment for the quadriceps muscles. If someone has Osgood-Schlatter's disease, which is a bony pathology that affects a lot of times young people who participate in power sports and involve jumping and running, the quadriceps tendon or patellar tendon pulls right on that tibial tuberosity. And if you have someone with who's young and doesn't have fully developed bones, you can actually get some hypertrophy of that bony aspect of the tibial tuberosity. And it's visible on the outside of someone's body. If they have Osgood-Schlatter's, you see that enlarged tibial tuberosity, and it can cause pain and knee dysfunction. So the proximal fibula, I don't have a fibula on me right now, but there's a diagram of one here. The fibula is the long, slender bone that courses along the lateral shaft of the tibia. And while the tibia is the main weight-bearing bone, the fibula has its role to play as well, particularly at the ankle joint, but it's an important attachment at the knee joint for some pretty important muscles and ligaments. So the fibular head is the rounded superior portion of the fibula that articulates with the tibia, and it forms the proximal tibiofibular joint. And it also is the distal attachment of the lateral collateral ligament and the long head and a short head of the biceps femoris, which are lateral hamstrings. So it's an important attachment point, and the tibia and the fibula are articulated at the knee and at the ankle, and in between we have the interosseous membrane, which helps direct some of the forces between the two bones. The patella is a small sesamoid bone. It's not as small as some sesamoid bones, but it's, you know, relatively small. And this one, it has a little wire attaching it to the femur. Our real patella don't have that, but it's embedded within the quadriceps tendon. So the superior pole of the patella accepts the quadriceps tendon. The inferior pole accepts the proximal side of the patellar ligament. The posterior articular surface articulates with the intercondylar groove, also called the patellar groove of the femur, and has medial and lateral facets on the posterior side of the patella. If you have patellofemoral arthritis, those articular surfaces are the ones that are affected. So the patella, it serves to increase the torque of the quadriceps by increasing the length of the moment arm. And we'll talk a little bit more about that function in a couple lectures. So we talked about in the hip osteology lecture, the normal angle of inclination of the head and neck of the femur to the shaft of the femur is 125 degrees, and it directs the shaft of the femur to the midline, so it can articulate with the tibia at the knee. So the femur usually meets the tibia not at a 180 degree angle straight up, but at about a 170 to 175 degree angle, and this is described as normal genu valgum. So genu means knee in Latin, and valgum is the knees going in towards each other. And the way I remember that is with valgum, the knees are gummed together. So less than 170 degrees is genu valgum or knock-kneed. Greater than 180 degrees is genu varum or bow-legged. So if you have an increased angle of inclination, the head of the femur is going to have to move inferiorly in order to articulate with the acetabulum correctly. And it is going to move the distal end of the femur laterally. So when you look at these two pictures, let me make them a little bit bigger. There we go. So basically, excessive genu valgum and genu varum describe excessive frontal plane deviation. Excessive angle of inclination or diminished angle of inclination of the hip also describe frontal plane deviation. So if you have, so I'm going to draw a little femur in here, a little head and neck of my femur in here. So that's the neck of the femur, that's the head of the femur. So if your angle of inclination is less than 125 degrees, the head of the femur will have to move down. The head of the femur will be down a little bit, and the proximal end of the femur will have to move laterally in order to articulate with the acetabulum, and that makes the distal end of the femur move medially, and you end up with this excessive genu valgum, where the knees are closer together. If you have an angle of inclination in excess of 125 degrees, the head of the femur has to move down in order to articulate with the acetabulum. It moves the proximal end of the femur medially and the distal end of the femur laterally, resulting in the more bow-legged or genu varum position. So I hope that makes sense. If it doesn't, please ask me and we will clarify. So when something happens at the hip, it affects the knee. So something happens at the knee, it can affect the hip. So the hip and the knee are interdependent. They share a lot of muscles. And so if one of them goes bad, there goes the neighborhood, and they all go bad.